Pulmonary hypertension. Pulmonary hypertension is systolic BP greater than 25 mm Hg, diastolic BP greater than 8 mm Hg. Any chronic lung disease leads to back pressure into the pulmonary artery, obstructing flow out of the right side of the heart. Primary pulmonary hypertension is by definition idiopathic. Any form of chronic lung disease such as COPD or fibrosis elevates the pulmonary artery pressure. Hypoxemia causes vasoconstriction of the pulmonary circulation as a normal reflex in the lungs to shunt blood away from areas of the lung it considers to have poor oxygenation. This is why hypoxia leads to pulmonary hypertension, and pulmonary hypertension results in more hypoxemia. Presentation: dyspnea and fatigue, syncope, chest pain. Wide splitting of S2 from pulmonary hypertension with a loud P2 or tricuspid and pulmonary valve insufficiency. Diagnostic tests: chest X-ray and CORT. Best initial tests showing dilation of the proximal pulmonary arteries with narrowing or pruning of distal vessels, right heart or Swan-Ganz catheter. Most accurate test and the most precise method to measure pressures by vascular reactivity. EKG, right axis deviation, right atrial and ventricular hypertrophy, echocardiography, RA and RV hypertrophy. Doppler estimates pulmonary artery, PA, pressure V. Q scanning identifies chronic P as the cause of pulmonary hypertension. CBC shows polycythemia from chronic hypoxia. Treatment: correct the underlying cause when one is clear. Idiopathic disease is treated, if there is vascular reactivity, with prostacyclin analogues, PA vasodilators, epoprostenol, treprostinil, iloprost, beroprost, or selexipag endothelin antagonists, bosentan, ambrisentan, macitentan phosphodiesterase inhibitors, sildenafil, tadalafil C-GMP stimulators, riochiguat calcium channel blockers. Oxygen slows progression, particularly with COPD. Oxygen is most effective when the etiology of pulmonary hypertension is lung disease that causes hypoxia. Treatment for primary pulmonary hypertension is unclear. It's uncertain which drug will open up or slow the closing of the pulmonary artery without right heart catheterization. When the catheter is in the pulmonary artery, you give each drug and see which one the patient's artery responds to. Only lung transplantation is curative for idiopathic pulmonary hypertension.